Sure. My name is Reed LaHaye. I'm a third-year medicine resident here at UAB. From Louisiana, Lafayette, Louisiana originally. Went to school up at Fordham for college, and then in New York, and then LSU Shreveport, and I'm doing Pulm Crit here next year. That's my basic life story.
When I say somebody needs to go to the unit, are you gonna give me a hard time?
Yeah, probably a little bit,
Okay.
and then I'll
Yeah,
grudgingly take
everybody
them.
else does. Okay, Gerline, why don't you introduce yourself? You're a superstar.
Hi everyone, I'm Gerline. I'm a fourth year medical student at Albany Med, and I'll soon be an intern at Brigham in a couple of months for internal medicine.
And Mario.
Yes, hi. My name is Mario. I'm a sixth-year medical student from Lima, Peru, and I want to go into internal medicine, hopefully in the States. So that's me.
Excellent, excellent. Well, we have plenty of people at UAB from Lima. We're very Peruvian friendly there. Why is my phone ringing and my wife not picking it up?
It's a landline. That's always
a landline, and I think it was spam.
It's a robocall.
No, it is definitely a robocall. If somebody heard that I was having a problem with my warranty on my car. I don't know why that always happens. Reed, why don't you tell us the story? Just tell us a little bit of the story and then give us the BMP.
Sure. So this is a 71-year-old gentleman who I saw on the VA wards last month. His chief complaint that he came in and got admitted for was bilateral lower extremity swelling and some abdominal swelling. And that may or may not be related to what we're talking about. So do you just want the BMP right now?
Yeah, so this guy gets admitted for one reason, and this BMP shows up, and Reed stops me in the hall and says, what do I do with this BMP?
So we have a sodium of 135, a potassium of 5.8, chloride of 106.
You'll have to slow down because sound's not that quick. It was 5.8, right?
Correct. Chloride is 106.
I'll get there eventually, guys. What's the BUN, Reed?
BUN was 27.
Excellent. All right. Hit me.
Chloride, we got bicarb 19.
Whoop.
Ooh.
We're gonna figure it out. Nobody panic. You said 19?
I'm actually having fun watching you try to figure out how to do this.
This is something else. All right. I think I'm there.
And then creatinine 1.3.
Excellent.
His glucose, I think, was like 127 or something. It was a touch high. Nothing.
That was interesting. Okay, Mario, you get to tell me what you're thinking.
Okay, when I hear bilateral leg swelling and abdominal swelling, I think I'm assuming it's pitting edema, and I'm thinking three things: is it a heart problem, a liver problem, or a kidney problem? In kidney problem, I'm thinking about is it a nephrotic syndrome or a acute kidney injury / chronic renal disease? Those two buckets.
Great. Go straight to the numbers.
Okay, when I see
straight to the numbers, we may use the presenting complaint later on. We may not.
Okay,
we'll see.
The sodium is on lower limit of normal. Potassium is high, slightly elevated, and what it's really markedly decreased is the bicarb. So, is this metabolic acidosis, or is this a compensation for a respiratory problem? Those would be my first thought.
Okay, Gerline, can you help him some? After you unmute yourself, Gerline. Did I lose Gerline? Gerline left us. She said she'd help and then she left. Oh, well.
Yeah, I don't see her on here. All right, no, wait.
Oh, here, she's back.
Oh, there we go.
Hi, Gerline.
Having some
We-
difficulty. Hello, can you
Yeah.
hear me now? My internet was just like stopped for a second.
Okay, so we heard Mario's analysis. I don't know if you heard it or not.
Yeah, I heard his, and then Can you
So,
hear me now?
well, why don't you expand on what he said, and then I'll tell you all how I'm thinking about this right now.
yeah. So I was looking at the labs. I was thinking about the acidosis and the hyperkalemia stood out to me, and looking at the gap metabolic acidosis. So I guess initially I was thinking about things such as like aldosterone affecting both the potassium and the acid levels. So thinking of hyperkalemia is usually associated with hypoaldosteronism. So thinking there's something going on there. Overall, when I think about non-anion gap metabolic acidosis, I think about things such as like, did the patient just get a bunch of normal saline that can cause a non-anion gap metabolic acidosis? Other things would be things like if the patient's having like diarrhea or losing bicarb somewhere in the GI tract, or if it's a kidney problem with more like a renal tubular acidosis. And then for hyperkalemia, I'm thinking more in terms of also thinking about like aldosterone, but also thinking about if there's some sort of like lysis leading to hyperkalemia or other causes that are outside of like the shifts between the intra and extracellular spaces.
So, can you put the hyperkalemia and the bicarb of 19 together?
So hypoaldosteronism usually causes hyperkalemia and metabolic acidosis. So thinking about if there's aldosterone deficiency, and then for renal tubular acidosis, usually have the different types you would differentiate by like a anion gap to see if it's a proximal or distal, to look at if you have enough ammonia regeneration to see.
Okay, so you both have a lot of right things. And what I'm going to do is I'm going to tell you how I thought about this when Reed told me about it. The first thing is that these are the classic numbers you get with type 4 renal tubular acidosis. All other renal tubular acidosis causes hypokalemia, as does diarrhea. So there's almost nothing else that can be. Now, why does it turns out that the hyperkalemia is what causes the normal gap acidosis. So are you ready for a physiology lesson? Mario, would you like a physiology lesson?
Yes, I think I actually remember the mechanism.
Good.
So yeah.
See if you can remind everybody of the mechanism, and then we'll go over it.
So I think in the proximal tubal cells, there's where ammonogenesis occurs.
Correct.
And when you have high potassium inhibits, I don't remember exactly the enzyme, but it actually inhibits the ammoniogenesis. So high potassium, lower production of ammonium, and ammonium is what permits more acid secretion.
That is 100% correct and beautifully stated. And let me just fill in the gap. Ammoniogenesis is mostly glutamine to glutarate, and the enzyme is glutaminase. And we were actually discussing the other half of this on rounds. High potassium inhibits ammonia production. Low potassium stimulates ammonia production. That's one of the reasons that hypokalemia is a risk factor for hepatic encephalopathy. Okay, why is ammonia so important? So, Gerline, do you know why ammonia is so important?
My Zoom disconnected for a second, so I missed what you were asking.
Okay. Well, I'll just do it. I'll just say it. So here's the deal. We eat acid in our diet every day. And the number to remember is approximately 1 milliequivalent per kilogram per day. We have two different buffer systems that the kidney uses to get rid of the excess acid. We have the titratable acid, which is phosphates. We can't really adjust that. That's just part of our dietary intake. And then what the kidney does is it makes ammonia, because ammonia is a beautiful buffer system. So let's remind you of the physiology, because if you really understand the physiology, then all of the renal tubular acidoses make sense. Ammonia is made in the proximal tubule, as Mario said, and it's from glutamine going down to glutarate under glutaminase. Ammonia goes into the proximal tubule, gets protonated, and becomes ammonium. Remember, ammonia is NH3, ammonium is NH4+. At the sodium potassium 2 chloride cotransporter, which is really a small cation cotransporter, ammonium goes into the interstitium, becomes part of the countercurrent mechanism. Immediately, because the interstitium is not acidic, becomes ammonia. And so you have a gradation from the medulla up to the cortex of concentrated ammonia down the medulla. Ammonia passively passes through the distal tubule. And if the distal tubule is able to make acid and decrease the pH, it takes microequivalents of acid to protonate milliequivalents of ammonium. So a classic buffer system where you have to use very little acid to get rid of a lot of acid, very few protons. So what can go wrong? Well, distal RTA is when you can't acidify the urine, so that we lose that buffer system. And that's probably around half, somewhere between 30 and 40 milliequivalents per day for an 80 kilogram man like myself. That doesn't hurt you for a few days, but sooner or later you get acidic. What happens in type 4 RTA is that type 4 usually occurs when you already have some kidney disease, and at 1.3, this creatinine, this guy may have a little chronic kidney disease. We'll learn more about that in a few minutes. And then we're making less ammonia. So as your renal function gets worse, you start to wash out that countercurrent mechanism, so the ammonia is less well concentrated in the medulla. This is why people with a creatinine of 3 or 4 often have a normal gap acidosis. They have less proximal tubular cells, so they make less ammonia, and they don't concentrate it as well. So even if the distal tubule is working perfectly, they just don't have enough ammonia to buffer. And that's why you see so many people who have chronic kidney disease who are on bicarbonate or Scholl solution. Does that make sense to everybody? So we have distal RTA, we have the RTA of chronic kidney disease, which is really not an RTA, but it is a normal gap acidosis. Proximal RTA is just a reabsorption problem. And type 4 RTA is we're making less ammonium. And if you correct the potassium, you're okay. What is the common reason, Mario, that people get type 4 RTA? What's the most common cause other than medications for type 4 RTA?
Well, I think if you have a problem with renin production, I think in diabetic nephropathy, you can have hyporeninism, and that would cause hypoaldosteronism. I'm not sure if that's the most common one, but that comes to mind.
Yes. So what happens is a subset of people with diabetic kidney disease, where's the renin made?
On the juxtaglomerular apparatus.
Right. And if you look at biopsies of the kidney, they get Kimmel-Steele-Wilson lesions and knockout the juxtaglomerular apparatus, not every one, but a lot of them. And if you knock out enough, you get enough hyporenin, you don't have enough renin being made, and therefore you get hypoaldo. So that's the classic hyporenin hypoaldo. What we have to ask for this patient and for any patient is that are they on drugs? So a lot of people with diabetic kidney disease are doing fine until we give a drug that blocks the RAS system. But we have an absolute reason to give a drug that blocks the RAS system, right? Is that right, Gerline?
Yeah, like usually give ACE or ARBs to inhibit like diabetic nephropathy.
Right.
That can inhibit your system.
So this is the big problem. This is the big problem. And Gerline, I know you're very interested in cardiology. These people also have heart failure. And so we want to give them ACE and ARBs for their heart failure. And a rate limiting step is they're going to get hyperkalemic. So this is not a minor problem. So if you're taking care of people with significant diabetes who have these lesions and have hyporenin, hypoaldo, this is not a curiosity in the textbook. This is a major, major problem in outpatient medicine, whether you're a general internist or whether you're a nephrologist or whether you're a cardiologist. So we need to know if this was stimulated by one of these medications. And people in the chat have already asked, certainly, Victor, thank you for mentioning that spironolactone can do this. Vishnu, Sjogren's causes distal RTA, does not cause type 4 RTA. So Sjogren's causes a lack of ability to maintain an acid level in the distal tubule. And they're hypokalemic, Vishnu. So that's important to understand the difference there. Bactrim. So how does Bactrim cause a problem? So Vishnu, you mentioned Bactrim, and do you know the mechanism?
I don't.
Good. Does anybody know the mechanism of Bactrim causing hyperkalemia? It's very interesting. So what is Bactrim? Bactrim is sulfamethoxazole trimethoprim, right? And it turns out that trimethoprim is a very similar chemical to miloride. And so it's like giving a miloride. And so just like spironolactone can cause a type 4 RTA, miloride can cause a type 4 RTA, especially if you're on the borderline. So it's really only with very high doses of Bactrim. The first time I heard of it was early in the HIV epidemic when they were treating patients with very high doses of Bactrim for their pneumocystis. But it still is something to be concerned about. Okay, so what we need to find out is the blood sugar is 127, but is he diabetic? Is he on an ACE or an ARB? And Travis was asking a very interesting question. Do you start ACE or ARBs first? I think more and more people are going to ARBs for two different reasons. The one is because less side effects, less cough, and less angioedema. And if they have heart failure, it's easy to go straight from an ARB to a neprilysin inhibitor and an ARB. And we're seeing our cardiologists go straight to neprilysin and ARB on the very first for heart failure. And that's different for diabetic nephropathy. Okay, so Reed, help us out. Does this guy have diabetes? Is he on any medications that we mentioned?
Sure. So he does have diabetes. His most recent A1C was 7.7%. He's had diabetes for, at least 5 years. He's had A1Cs as high as the 9s and 10s. In terms of some of these medications y'all were talking about, he's actually been tried on lisinopril and I think spironolactone at one point, but these had to be halted due to hyperkalemia. He had his potassium go as high as I think 6.1 to 6.3, and so these needed to be stopped. So he's not currently on any of these.
And was he put on the ACE for hypertension, for proteinuria, or for heart disease?
He was put on the ACE for hypertension and proteinuria.
Great. So do you have a urine protein creatinine for us?
Yes, indeed. So urine protein is 42, creatinine 25.7, or a ratio of 1.63.
And that's sort of a classic diabetic nephropathy. They often don't get nephrotic syndrome. If you remember the KDIGO classification of chronic kidney disease, this is grade B proteinuria. So they have A, B, and C proteinuria. 0.03 to 0.3 is A, 0.3 to 3 is B, and greater than 3 is C. What's his estimated GFR?
So for his age and everything, it actually just says 55.
Okay, so many of you have heard me say this before. There's a debate as to whether stage 3A is really a kidney disease, and stage 3A is 45 to 59. But when you have proteinuria, it is kidney disease. So this guy has early kidney disease, and in 2021, our job is to try to prevent this guy from progressing to dialysis. Now, the odds are he will not get to dialysis. Gerline, do you know why that is?
It usually takes a while to progress for diabetic nephropathy. He doesn't have like rapidly progressing glomerulonephritis or anything like that.
Yeah, but he said, he still could get there. So why else? What do people with stage 3A and stage 3B chronic kidney disease die of before they get to dialysis?
Heart disease?
Yeah. So coronary artery disease is the big risk, and heart failure is a big risk. And so when you talk to nephrologists, they'll tell you that this guy is a setup for heart disease, and we need to do things to try to prevent heart disease in this guy. People have mentioned the SGLT2s, and I agree 100%. I want this guy on an SGLT2. We'll talk about that in a second, but that's not that doesn't help us with this potassium of 5.8 and whether or not we could get him on an ARB to be synergistic with SGLT2. So what are the two drugs that nephrologists and cardiologists are using in this situation if they really are concerned about trying to get them on an ACE or an ARB and not have hyperkalemia? So this is not as fair a question for Mario, and it's really a tough question. It's really a tough question for Gerline because I don't think this is on the test yet. It might be on renal boards. Somebody mentioned one of them. So there are two new. So Vishnu actually got them both. So Vishnu, you're doing a heck of a job. Appreciate it. Okay, so there are two new potassium binders that are expensive, but you would have to think, is it worthwhile in a patient like this to do it? Patiramir is the trade name Valtessa, and Fernand says ZS9, which is Lokelma, which is zirconium chloride something or other. But these are two drugs that you can give to lower the potassium to allow you to use the ACE, ARB, and maybe even spironolactone if necessary, by controlling the potassium. Because if you control the potassium, you probably are going to control the bicarbonate. Now, this patient may need bicarbonate at first and may need it later on because he may or may not have two different mechanisms going on. So now we know the guy has diabetic kidney disease, and this is the classic conundrum. This is absolutely the classic conundrum that we have in outpatient medicine. We see it in inpatient medicine, but it's the classic conundrum of having an indication to try to slow down the proteinuria. If we slow down the proteinuria, we can slow down the progression of kidney disease. And if we slow down the progression of kidney disease, then we protect Gerlene's heart. I don't know why it's your heart, Gerlene, but seemed reasonable. Does that make sense to everybody? So Reed, tell us more about what you did and what you thought about and where all this stands.
Yeah, so, I was curious about this BNP, looking at this, I mean, he's had this hyperkalemia for, years. It's been at about this level, and same with the acidosis. And so I was curious about why that might be. And one of the nephrology attendings was actually attending for one of the other ward services. So I just kind of ran it by him. And we looked at his trend. So one thing about his creatinine, this is kind of his baseline creatinine, but he's actually been a good deal lower in the past. A few years ago, his creatinine really ran in like the 0.7, 0.8 range. And it's just been steadily rising over time. And this is in the setting of persistent proteinuria that's also been going on for years. So our nephrology friends kind of said that, maybe he may have a little bit more CKD than his GFR is necessarily letting on. This may actually be a more significant CKD. And they suggested starting him on bicarbonate tablets for his acidosis and something to kind of lower his potassium. In his case, we're trying out chlorthalidone. And to kind of round out the rest of his hospitalization. So I'll say his edema was not very impressive. When I went to go admit him, I was not blown away by the extent of his lower extremity edema. I mean, he definitely had a little bit, and it extended fairly far up to his trunk, but he was doing fine on room air. His BNP, pro BNP, I don't think was terribly remarkable. We ended up getting an echo on him just to make sure we're not missing heart failure. He had a preserved EF, no huge diastolic dysfunction. We also got an abdominal ultrasound. He'd had kind of a history of hepatic steatosis at one point. I'm curious if this had progressed to cirrhosis. It had not. His LFTs had all been pretty normal. We ended up giving him just a touch of Lasix. Well, not in his case, and maybe like, I think 100 or so of Lasix, and he said it kind of felt better.
His albumin was actually okay.
His albumin was fine. Yeah.
Okay, so let's talk about estimated GFR. And I think some of you heard me rant and rave about this before. And if you want to hear even more ranting and raving, there's a podcast that I did that was partly about whether we should include race in the estimated GFR equation. And my guest argued that was no longer necessary. But the biggest thing he talked about was how wide the confidence intervals were for the estimated GFR. And if you don't own this concept, if you own this concept at the end of our discussion today, then you have won a big victory. And that's exactly what Reed said, is that the estimated GFR is merely an estimate, and this guy might really have a GFR in the 30s or 40s, or he might not. And there are a couple things you could do. You could do a Cockcroft-Gault, which our PharmDs do, and people were asking for his BMI because BMI does if we have the weight, we can make some adjustments for different weights. Another way is to use cystatin C. We don't have that available at our hospital, but some hospitals you can estimate GFR or cystatin C, and if it's quite different from the creatinine estimate, that might be a clue. You can actually, at some places, you can do a variety of different tests to get a more accurate GFR. This is to me, one of the biggest problems we have in understanding chronic kidney disease. And I'm so glad, that's one of the things I wanted us to discuss, because Reed had brought that up to me, that we didn't really know what his renal function actually was. And if you don't know what the renal function actually is, it makes it harder to figure things out. The fact that he has significant proteinuria and he has persistent hyperkalemia suggests that it's something worse. Now, the other possibility is that it's not diabetic kidney disease, but some other proteinuric kidney disease. I've recorded a podcast that will come out in another couple of months. There's a project going on from the American Society of Nephrology called Kidney Precision Medicine Project. And what they're doing is they actually are biopsying a lot of these people and finding out in people with diabetes who present like this or present in any way, what's the probability that it's the diabetes that is causing the kidney disease as opposed to something else? And what are the clues? And when I talked to the two experts, they told me that diabetic kidney disease is likely not one disease. It's probably 4 or 5 different types of manifestations. That makes sense, because if we see someone has heart failure, there's a lot of different reasons people have heart failure. Well, there's a lot of different reasons people with diabetes have kidney disease. And so I think that's a really important teaching point that Reed brought up, that we're not really sure how bad his kidney disease is. But we do know that he has type 4 RTA. And I think what the nephrologist is trying to do is see if we can increase his potassium excretion with chlorthalidone, which is a long-acting thiazide diuretic and does have, when used by itself, has a problem with hypokalemia. So maybe that would lower the potassium. Yeah, so Vishnu mentioned the paper that talked about race, and there's a podcast that's associated with that paper. So thank you, Vishnu. Travis wants to know, how can we call an acidosis in this situation? And it's by deduction only, Travis. I think that you make a good point that unless we have a VBG, we can't be 100% correct. So you just wouldn't see hyperkalemic. He has no history of GI loss. Now, we could go through the process. Could this be compensation for respiratory alkalosis? He also doesn't have a reason for respiratory alkalosis that we're aware of, and that should not cause hyperkalemia. I think this is one time where we can just take the numbers and believe them. I love Travis's point, but I'm not concerned about whether this is a type 4 RTA or not. There's a really, look at the chat. There's a really interesting conversation going on about using race. I really highly recommend listening to this podcast to understand what all the fuss is about, because it's fairly legitimate. All of these calculations are estimates, and they have wide confidence intervals. It turns out the confidence interval for different ethnicities and people of East Asian descent, have one association difference that has been suggested, but all of these have such wide confidence intervals that we have a real problem, and there's a significant chance, as is said here, is that that we probably are overestimating the GFR in many African Americans, and therefore referring them to nephrologists too late. So I think that that's more and more becoming the belief of most nephrologists, that there was a legitimate reason that they put race in, but they didn't like everything else, they didn't understand the unintended consequences. Anyway, so what are the big take-home messages? So Mario, what do you take from all this?
I think I take two things. One, if you are dealing with metabolic acidosis and hyperkalemia, I think that's virtually the only diagnosis is maybe a type 4 RTA. I can't think of anything else. Usually those acidosis come with hypokalemia. So that's one. And I think that's what I basically take away.
Okay, Gerline.
Yeah, I think my major takeaway is related to the fact about how sometimes we don't really know how well the kidney is functioning in terms of the GFR can't necessarily be used to tell us how much kidney function there is going on. So that's important takeaway. And the other thing was that sometimes the importance for diabetic nephropathy is treating with ACEs and ARBs, but they lead to hyperkalemia, and just that there's these new drugs available like lokelamine, patisiran, so that we can prevent the progression of disease, but still manage the hyperkalemia. I think those are the two things that were really helpful from this discussion.
And in the chat, though, you'll see that these are really expensive drugs. And so nephrology and cardiology are really excited about them. But there is a cost, there's a real cost to these binding agents. They're very safe, but they're really expensive. And as Reed has just put in there, at RVA, it's really hard to get them approved. So they want you to try everything else for good reason. For good reason. Reed, what is your big take home from? You stopped me in the hall to discuss this case, and what do you know now that you didn't know when you first started thinking about this case?
Yeah, I think, it was a great review of diabetic nephropathy for me, what it can do. In particular, when I was going down the pathway for RTA, a type 4 RTA, it's kind of believed his is probably not necessarily a state of deficiency or aldosterone deficiency, but an inability to respond to it appropriately because of the CKD. And that was a nice little review of physiology for me. And also, how important it is to treat this hyperkalemia in these patients for the reasons we've mentioned, that, this guy needs to be on some kind of therapy for his proteinuria to hopefully delay the progression of his disease. And so I feel like it's easy, particularly when you're in the hospital a lot, to just sort of see these slightly elevated but not life-threatening potassiums and just sort of say like, well, kick it down the road, someone else take care of it later. But this could have very real effects for this guy. So yeah.
What was he on for his diabetes?
He was on a bit of insulin. I don't remember his exact regimen, and some metformin. So he definitely had some room for some oral stuff.
Yeah, so this is a preview of the podcast that I recorded last week that won't be out till May or June. So there's this wonderful woman, Dr. Kathy Tuttle, who I've had on 2 previous podcasts, who was on again with me as part of that kidney precision medicine thing. And I asked her the question, if you have someone with type 2 diabetes who's on insulin, can you put them on an SGLT2? And she said, absolutely. I said, do you have to worry about about diabetic ketoacidosis? And if you've listened to podcasts with her, she's both an endocrinologist and a nephrologist. So she takes care of a lot of diabetic kidney disease. And what she said is, you put them on an SGLT2 if they're starting to have hypokalemia problems. You continue the insulin as before, and if you're starting to get hypokalemia, you cut down the dose of the SGLT2. And what she told me, which was very interesting, and I didn't realize, was in the studies, all the benefits from SGLT2s, both in diabetics and non-diabetics, don't seem to be dose related. And so cutting the dose down of an SGLT2, it still seems to help both the proteinuria and therefore the decreased progression of disease and stabilize the heart failure. And remember that it is that SGLT2s are diuretics. So I asked her about type 1 diabetes. She says the studies are underway. But for people who are interested in either nephrology and or heart failure, SGLT2s are indicated for all those people. Now, how much do they cost? Somewhere between $500 and $1,000 a month. The question is, does that make sense? These are US dollars. I have no idea what it costs in Peru, Mario. I'm sure everything is less expensive someplace else than the US. We always have the highest. They cost a lot less elsewhere. Do you know how much Medicare pays on average for a dialysis patient per year? Does anybody know that number? $100,000 per year. $100,000 per year. 110,000. Okay, Travis, that might be a better number. So when you think about the number needed to treat to delay progression of kidney disease, and with the SGLT2s, they essentially stopped progression of kidney disease almost cold. And this is at least down to GFRs in the 30 range. And they're testing it now even lower than 30. And so a patient like this, and this was suggested in the chat, and I agree 100%. If we're not going to be able to get them on an ACE or an ARB, an SGLT2 might take care of the problem for us because we're not going to get hyperkalemia from that. And so even though it's expensive, it probably for the entire healthcare system, it might even be cost saving. There is what she told me is that there's a cost of benefit analysis in Australia, and they save money by giving SGLT2s because less patients get to dialysis, and dialysis is so expensive, not just for the dialysis, but for all the hospitalizations they have and the heart disease they have. And so the nephrologists, when you hear nephrologists talk about SGLT2s, there's a certain kind of ecstasy that is unusual in nephrologists. And they have these epiphanies and they get all excited and start jumping up and down. But this is the big deal for them. But I think as you look at the data, that's really very clear. Okay, Fernand, explain roxadustat, because I've been reading about roxadustat. I'm very excited, and I actually listened to Freely Filtered last week just so I know what roxadustat is, and I can say roxadustat. So Fernand, tell everybody this is not at all relevant to what we were just talking about, but it's so cool that I'm going to let Fernand tell you because it's a cool hematology drug.
Yeah, I think it's probably going to be the medication for the nephrologist when it gets approved. It's already approved in China. It's a medication that's meant to replace ESAs, basically erythropoietin agents. And I can't remember the target exactly. It's something related to the HIF-PIF, so something related to the hypoxia-inducible factor that is stimulated by hypoxia. So it kind of it mimics hypoxia to decrease the degradation of this factor, and it like stimulates an environment where you have pseudo hypoxia. In that case, it increases endogenous erythropoietin instead of giving exogenous erythropoietin to stimulate erythropoiesis in a CKD patient. You rely on your own body's erythropoietin, and the advantages, at least in theory, are prevention of cardiovascular side effects such as hypertension and stroke. The increase in hemoglobin is really impressive, and it's a pill you take every day instead of being injected with EPO. And it seems like, at least from the initial studies, that there are no major cardiovascular problems or clotting problems. And that's the general feel about this class of agents. There are multiple ones in development. Roxadustat is the one that is most further down the pipeline, and it's coming, I guess, to the USA. There were some hurdles recently, I believe. I can't remember if there were some safety problems, but it's probably going to happen at some point.
Yeah. They thought it was going to be approved recently, but they're delaying it. The key phrase here is Dustat, and I don't know why it's called Dustat, but there are other Dustats, and the nephrologists are almost excited about this as they are about SGLT2 inhibitors. So all of a sudden, the nephrologists are, they have new toys, and so they're all happy. Sal, you get the last word, since you were our great scribe and gave us all the pearl and thoughts about what you're thinking about.
Thanks, Dr. Santor. I really appreciated the learning points and a lot of great pearls. Great case by Reed. I'm going to pivot back to something that Vishnu said, and I'm just thankful that he mentioned that a lot of these calculators we have in medicine that have race as an input, and just comment that race is often used as a proxy for genetic diversity, which it's not. It typically is a reflection of prior racial disparities in health, and as a result, they might propagate disparities and lead to under-referral for things like PFTs and CKD. So I just want to shout out Vishnu and thank you for that.
Hey, this is Travis. Regarding the GFR, do you guys use the the GFR that it's given, for an African American, or are we supposed to just be using, what it's giving for the Caucasian? Because I mean, the numbers are grossly different, which are noticeable. But you could have someone that has one of 61, but then the Caucasian GFR, would be 47. So I mean, if there's a big difference there, what are you guys doing, and what should I be teaching?
Yeah, more and more hospitals are taking race out of the equation, and I think within a couple of years that we will have removed race from the MDRD and CKD epi equations.
Does your hospital use it now?
I don't know.
I mean, it tells me, like on my BMP, it gives me, estimated GFR in 2 equations, and it tells me if it's Caucasian or non-Caucasian.
Yeah. As I think it was Vishnu said, race is not a genetic construct. It's an anthropological construct. It's a social construct, and so it's really a falsehood to try to say these people and those people are dichotomous. Everybody runs into each other, and so it's really leaving race out of these equations probably is a really good idea. But I highly recommend listening to the podcast, because he does a better job of explaining it than I ever could.
Will do. And I mentioned BMI earlier with the creatinine, because if the patient's BMI, was 20 or 17, they have no muscle mass. So their creatinine, even though it says 1.1, if they had muscle mass, it would be a lot higher.
Yeah, we've had patients with estimated GFRs of over 300. Of course, they had cord injury and had like no muscle mass, or they're cachectic and had no muscle mass. And so you have to take all those things into consideration. And that's why there's a beauty to the estimated GFR, but one of the things that I really stress every time we do one of these, and when I start converting some of these into podcasts, I'll definitely talk about it often, is it's an estimated number and you have to take the patient into consideration. I was so glad that Reed brought that up because it seems like he doesn't have very much kidney disease, but yet he has all this proteinuria and he has type 4 RTA. So he probably has a much worse renal function than his creatinine says. So with that, thank everyone for logging in. We are going to discuss a thoracentesis next week, which should be fun. It's a very interesting one. And then the 20th will be a day off because of a prior commitment. And then we're going to start radiology, I hope, on the 27th. I think we're going to do some GI radiology. Yes, Fernand. And then we're going to, I know for sure we have at least one GI radiology day and one pulmonary radiology day already being prepared. Have a great evening.